Okay, so we are continuing with connective tissue. We had some technical difficulties. So we are continuing with connective tissue, and where I left off was comparing, let's say, the knee joint that I have here. You can see that the knee joint, if I remove this, we can see that it's kind of unstable here. We have round structure and a flat structure. So what the innate intelligence of the body does is it puts a lot of soft tissue, ligaments on all sides of the knee, in the back, on the outside, in the front, on the inside, between the femur and the tibia. We do have lots of ligaments there, as you can see. Okay, so the ligaments around the knee need to be more collagen for strength and stability. Otherwise, the knee would be dislocating everywhere. So that's the difference between where we need more elastic connective tissue and perhaps where we need more collagen. When we look at fluid connective tissue, we're thinking of blood and lymph. When we think of blood, we're thinking red blood cells, white blood cells, and platelets. Red blood cells are known as erythrocytes. They're going to carry oxygen and carbon dioxide and nitric oxide. And white blood cells we think of as our internal warriors or our soldiers. These are going to help us fight off infections. White blood cells are also known as leukocytes. There's cytes for cell. Leuko means white. Erythro means red. Platelets help us clot. So when we bleed, platelets are involved with clotting. If someone were to take baby aspirins, they inhibit platelets so that you have thinner blood and you're not clotting as easily. For those that are more holistic and want to take a more holistic approach, which I always applaud, things like niacin thin the blood, and fish oils or omega-3 quality fish oils do that. Garlic can do that. Red wine or resveratrol can do that. I wouldn't do all those things together, but they do have synergistic effects in keeping the blood nice and thin. Lymph is the interstitial fluid, meaning the fluid that we find between the cells, and the body is cleansing and filtering that to return healthy fluid back into general circulation. In terms of supporting connective tissue, this is where we have cartilage and tendons and ligaments, right? So especially cartilage and ligaments. Cartilage is avascular. Whenever we put the letter A in front of something, it means without. Vascular is blood vessel. So cartilage does not have blood vessels, which means when it gets damaged, it takes a longer time for it to heal. Same thing with ligaments. Doesn't have the best blood supply, so it takes a long time for ligaments to heal. In terms of cartilage, the three main types are hyaline cartilage, elastic cartilage, and fibrocartilage. Hyaline cartilage is what we have here between our joints. Hyaline cartilage is the cartilage that we find between freely movable joints. It's sometimes called articular cartilage because it helps two bones articulate. It's called articular cartilage. So that's hyaline cartilage. It's the most common type, and it's going to cover the ends of the surfaces of the bones. Elastic cartilage allows for tissue flexibility. When I think of elastic cartilage, I'm thinking about the cartilage in the nose, cartilage at the epiglottis, cartilage in the ear. You can all distort its shape, and then due to its elasticity, it bounce back. Fibrocartilage is the strongest cartilage of the body. This right here, the meniscus of the knee, where we have a lateral and a medial meniscus of the knee, that happens to be fibrocartilage, as well as the intervertebral discs. Those are fibrocartilage. Here we're looking at a structure where we see a bunch of cells in here, and we have to go, well, is this lamellae with osteocytes? Is it lacunae with chondrocytes? Is it collagen fibers? Is it matrix of hyaline cartilage? What is this structure? And you really won't know until you look at what hyaline cartilage looks like. You have to be able to look at it under a microscope. So what we're seeing here, what is highlighted, right? Typically on these type of questions, it'll ask, what structure is highlighted? Now everything's pretty much pink. The only thing that's different is this. So what is the tissue? What is the substance, I should say? What's the substance that's between the cells? So we have a bunch of cells that are not closely packed together. We have lots of matrix. So this is matrix of hyaline cartilage. This happens to be hyaline cartilage. Okay, another type of connective tissue is bone. And when we talk about compact bone, we have something called osteons. Osteons are only found in compact bone. When you learn about bone, and I believe I sent out a video earlier today, but it's also on my YouTube channel, where you can learn about bone physiology and you learn the relationship between osteoblasts and osteoclasts. Osteoblasts pretty much build up bone, whereas osteoclasts break down bone. So osteoblasts create the matrix and osteoclasts break down the matrix. Osteoblasts with a B build up bone, osteoclasts break down the bone. Osteoblasts are a type of cell that's going to make its matrix. It's going to push out calcium and hydroxyapatite. I think of it as the cement, right? It's creating the cement, but eventually cement hardens. And when the cement hardens, the osteoblast gets stuck. It gets stuck in its own matrix and it can't get out. So the osteoblast now matures, and the osteoblast evolves into an osteocyte. Okay, so the osteoblast produces the matrix, it gets stuck after the cement hardens, and now it's not called an osteoblast, it's called an osteocyte. And the osteocyte is stuck in a cavity called a lacunae. The lacuna, or the lacunae, is the cavity in which it now resides. An osteoclast is a type of cell that breaks down the old matrix. On one of the discussion board posts, we were talking about anabolism and catabolism and building up and breaking down. And one of my contributions on the discussion board was that the body does this all the time, not just with food, right? Like taking in a hamburger with carbohydrates and fats and proteins and eventually breaking that down, catabolism, only to build up the body, anabolism. Bones break down due to osteoclasts and build up by osteoblasts. They're constantly being broken down and built up, broken down and built up. Same thing with red blood cells, same thing with the skin. Everything is being made and being broken down. Catabolism and anabolism. Catabolism is breaking down, anabolism is building up. So the lacunae is the cavity in which the osteocyte lives. The periosteum is the outer layer of bone. The endosteum is the inner lining of bone. And the central haversian canal is what we see in the center. So when we look at compact bone, we see a bunch of these concentric rings. This is compact bone here, and in the middle we have spongy bone. Spongy bone looks like a sponge, compact looks more solid. It looks like the appearance with all these concentric rings looks like someone chopped down a tree and you're looking down on it. Each of these is called an osteon. Osteons are only found in compact bone. So when we look here, this looks like a tree that was cut down with all of these concentric rings. That's an osteon. Each of these hollowed out regions, like we see here, each of these is a lacunae. That's a lacunae, that's a lacunae. All of these black hollowed out sections are lacunae, which is where the osteocytes live. The central canal is this. This is where you have your blood vessels. And lamellae are just these concentric lamellae, these rings that go around, all the way around. So the characteristics of connective tissue, most connective tissue is highly vascular, good blood supply, with the exception of cartilage. We said it's avascular. Tendons and ligaments, it's poor, right? It's got poor blood supply. So we did epithelium, we did connective. Let's look at muscle. Muscle is pretty straightforward. We have three different types of muscle: skeletal, cardiac, and smooth. Skeletal is the only one that's voluntary because you can move your arm, you can move your leg, you can voluntarily contract your muscles. That's skeletal muscle. Any muscle that attaches to your skeleton is skeletal muscle. It's voluntary, consciously controlled. Whereas the heart, for cardiac muscle, you can't speed up or decrease your heart rate instantaneously. Now, you could do it over time. You could, right? You can meditate, you can listen to relaxing music and decrease your heart rate, but it may take a little bit of time. You can have stressful thoughts and increase your heart rate, but for the most part, right, it's involuntary. Smooth muscle is around your arteries and around your veins and around your organs, right? You can't dilate your artery to decrease your heart rate and to decrease your blood pressure. A woman cannot dilate her uterus, right? During the time of month when a woman's monthly bill comes, right, and she's feeling contractions around the uterus, there's cramping due to those involuntary spasms. Okay, that's smooth muscle. What tends to help women during that time of month is chocolate. Why is it chocolate? Especially dark chocolate. It's high in magnesium. And magnesium is a natural muscle relaxer. Brazil nuts are high in magnesium as well. But, when I survey most of my patients, most women crave chocolate, not so much Brazil nuts during that time of month. Here's what skeletal muscle looks like. When you look at skeletal muscle, it's referred to as striated because under the microscope, you have these dark and you have light that passes through the protein filaments, creating these striations. So skeletal muscle, whether it's the triceps or the biceps or the quadriceps, it's voluntary. Whereas cardiac muscle is highly branched. It is striated. It does have striations, just like skeletal muscle has, but the big difference is that skeletal muscle is highly branched. You see here under the description, it is branching, right? Many different branches. And what's unique are these intercalated discs. You see these intercalated discs running in this fashion. We don't see any of those when we look at skeletal muscle. These intercalated discs are where one cardiomyocyte and another cardiomyocyte, where they come together and unite, that creates a gap junction. That's the intercalated disc. Very fast, rapid forms of communication take place in the heart so that both atria contract at the same time and then both ventricles contract at the same time. We need fast, rapid forms of communication at the heart. Smooth muscle looks very spindle-shaped. It looks smooth, and we find these around our digestive tract. We find it around arteries, veins, the uterus, things that you can't voluntarily control that need to constrict and dilate. That's where we have smooth muscle. The last type is neurological, which is the neuron. That is the fourth type of tissue, is called nervous tissue. The nervous system, I typically refer to it as the neural system. I just don't like using the word nervous because I don't like to be nervous. I don't like people to be nervous. So I often use the word neural system. So the neural system has two types of cells, a neuron, which is what we see here, and then it has neuroglial cells, also known as neuroglial cells. Neuroglial means nerve glue. They're supporting cells. The neuron, what we see here, is electrically excitable. The main parts of a neuron are these branches here called dendrites. It comes from the Greek word dendra, which means branches or tree-like. It has a cell body known as a soma or a cell body. And then it has an axon, which is this one long branch that leads away. At the end of the axon, we have terminals, known as the axon terminals. So the dendrites bring sensory information into the cell body or into the soma. And then the axon sends that electrical conduction away, all the way to the axon terminal. And the axon terminal stores neurotransmitters. Maybe GABA, maybe acetylcholine, maybe dopamine, whatever the chemical messenger is here, which is the neurotransmitter. Sometimes it's an on switch message and sometimes it's an off switch message. So neurotransmitter can be excitatory or inhibitory. They can stimulate a response or inhibit something. This here, the myelin, I believe this also came up in one of the discussion board questions in someone's response, where the myelin is produced by Schwann cells. The Schwann cell, which is a neuroglial cell, the Schwann cell produces myelin in the peripheral neural system, and oligodendrocytes produce myelin in the central neural system. The CNS is the brain and the spinal cord, and the PNS, or peripheral neural system, is everything except the brain and the spinal cord when it comes to neurology. The myelin is fat. It's cholesterol and fat. It's basically an insulator. It protects, insulates, and speeds up the electrical conduction system. And there's a disease known as MS, which is multiple sclerosis, which is when the individual is unable to produce this myelin because the person's immune system is attacking these Schwann cells or oligodendrocytes that produce myelin. Okay, now we'll look at the skin. And the reason why we look at the skin first in terms of systems is because we've covered the 4 different types of tissues. And skin has all 4 types of tissues, right? The skin has epithelium, which is up here, stratified squamous epithelium, at least 25 to 30 layers worth up here. Then we have the dermis, the deeper layer, and that's where we have connective tissue. That's where we have neurological tissue. That's where we have muscle. That's where we also have epithelium. We have glands. And then we have in the hypodermis, we have fat, we have adipose. So we have everything in the skin. We have epithelium, we have connective, we have muscle, and we have nerve. These laminated corpuscles, these allow you to feel pressure, right? So when you're walking and your calcaneus or your heel hits the ground, how does your brain get the signal that your foot landed, time to take the next step, right? We need pressure receptors for that. So the skin has this upper layer, which is the epidermis, and then we have the dermis, which only has 2 layers. The epidermis has 5 microscopic layers. We'll talk about them in a second. The dermis only has 2 layers, papillary and reticular. But you can see there's muscle here, there's some nerve. We have glands. We have an oil gland called a sebaceous gland. We also have sweat glands. So we have sweat pores, right, to allow you to perspire, to cool the body off. We have fat cells down here, adipose. We have muscle cell called the Erector Pili muscle. You know what the Erector Pili does is when this muscle contracts, it pulls on the hair follicle and makes your hair stand on end, giving you goosebumps. Part of that sympathetic fight or flight response. So here's just another a model of that showing the same structures. The Pacinian Corpuscle is neurological for pressure. The Meissner's Corpuscle up here is more for pain and temperature. That's more superficial. Here again is the Erector Pili. Here's your sebaceous gland that secretes oil up the hair shaft. So when you learn about glands, you're going to read about apocrine glands and merocrine glands and holocrine glands. So you need to know those different classifications. So now here's like a click and drag concept that you'd have to be able to figure out. So blank is a network of cells that monitors the internal and external environment that initiates commands throughout which the body reacts. So that's the neural tissue. Blank can be classified using the number of cell layers and the shape. Well, that was the first one that we covered, called epithelial tissue. Well, which type has skeletal, cardiac, and smooth? That's all muscle. Skeletal muscle, cardiac muscle, and smooth muscle. Muscle is widely distributed throughout the body to allow for movement of the skeleton, especially skeletal muscle. Blank is diverse, abundant, and widely distributed. The most abundant is connective tissue. Blank forms the surface layer of the body. It lines the cavities, the tubules, hollow organs, makes up glands. That's epithelium. And then it's composed of two types of cells. We finished up with that before. I said it's the neural system is made up of a neuron and neuroglial cells. Glial means glue. Neuroglial cells. You'll learn about them when you cover neurology. You have astrocytes. Astro means star. They look like stars. You have ependymal cells that make cerebral spinal fluid. You have microglial cells that are like a macrophage that engulf foreign particles. You have Schwann cells and oligodendrocytes and satellite cells. So you'll learn about the glial cells when you cover neurology. Here's another type of questions in which you'll have to drop and drag. So you'll have to know, well, does this fall under fluid connective tissue, supporting connective tissue, or connective tissue proper? So in terms of supporting, well, that's the stuff that we covered, like hyaline cartilage, elastic cartilage, fibrocartilage, and bone. That's all supporting connective tissue. Fluid connective tissue is blood and lymph. Connective tissue proper, that was where we had areolar connective tissue, adipose, and reticular. Then dense regular, dense irregular, and dense elastic. That's connective tissue proper. Same concept, just click and drag. You know, all right, smooth muscle and cardiac muscle fall under muscle tissue. Nervous is nervous tissue. Simple squamous, stratified squamous, simple columnar, pseudostratified columnar. Those are all types of epithelium. And then hyaline cartilage, compact bone, elastic, areolar, and adipose. Those are all connective tissue. Are you supposed to know these now? Absolutely not. You have to study this. You have to kind of organize them yourselves. So if you feel a little bit overwhelmed right now, normal, you're human. But when you start to compartmentalize and organize your studying, you'll be able to do this just as I can. In terms of hyaline cartilage and elastic cartilage and fibrocartilage is the strongest. What I said earlier was one of the classical examples was the menisci, or the meniscus, the medial lateral meniscus of the knee. It's also the intervertebral discs, the cushioning between each vertebra. And then where your pubic bones come together, there's a vertical cartilage called the pubic symphysis. In terms of elastic cartilage, that's the ear. You can bend the ear and it can alter its shape, and it's elastic and bounces back. The eustachian tube inside the inner ear. And the epiglottis, that's elastic cartilage, that it's this cartilage that folds down so that when you swallow, the food doesn't go down your windpipe. It closes off the windpipe or the trachea. And then hyaline cartilage we find at the end of bones. It's that articular cartilage between freely movable bones. Rings around the trachea, the thyroid cartilage of the larynx, and right between the nose, the nasal septum. That's all hyaline cartilage. Elastic cartilage is composed of branching elastic fibers. Fibrocartilage is made up of type 1 collagen fibers. They are very thick. They're also parallel bundles of collagen fibers, whereas hyaline cartilage is composed of type 2 collagen fibers. Now, type 2 collagen fibers, these are found quite a bit in a lot of advanced nutraceuticals when I prescribe a lot of nutraceuticals to patients that may have degenerative joint disease or osteoarthritis. And when I look at these high-end products, I'll find things like type 2 collagen fibers. Okay, and that helps to regenerate a lot of the degenerated cartilage between bones. Because remember, cartilage doesn't have a great blood supply, so the body really does need assistance in regenerating that type. Here we have connective tissue as the main topic, and then we have connective tissue proper, supporting connective tissue, and fluid connective tissue. We said fluid connective tissue is blood, and we said it's lymph. Under supporting, we said that's cartilage and bone. And remember, under bone, there's compact bone, which is where the osteon is, and spongy bone. Under cartilage, it's hyaline, elastic, and fibrocartilage. Under connective tissue proper, it's loose and dense. Under dense was regular dense connective tissue, irregular dense connective tissue, and elastic connective tissue. Under loose, which is what we opened up with, was areolar, adipose, and reticular. So you need to know how to categorize these. Okay, let's look at bones. I know we're moving kind of fast, but let's look at some of the bones. What is the highlighted structure here? This should be pretty straightforward. Remember, when you study bones, you're going to be looking at them in the axial skeleton, which is everything we see here in the center. And then we'll look at the appendicular, which is the upper and lower extremities. So here we have the 12 ribs. And notice the 12 ribs attached to the 12 thoracic vertebrae. This is why when someone has a scoliosis, right, when someone has a curvature of the spine, we can use the ribs as a biomarker to determine if they have a scoliosis, because the ribs will rotate forward, anteriorly, or posteriorly with a scoliosis. We could see here the highlighted structure are going to be the thoracic vertebrae. Up here are the 7 cervicals, and down below are the lumbars. We have the right innominate, the left innominate, sacrum, and coccyx, sometimes known as the pelvis. We can see the scapula up here, and a little bit of the humerus and a little bit of the femur. What's highlighted up here, based on the choices, well, it can't be sacral, that's down here. Can't be lumbar, that's here. Can't be thoracic, that's here. Can't be coccygeal, that's down here at the tip. It's got to be the cervical vertebrae, the 7 cervicals, C1 to C7. Then you have T1 to T12, and then you have L1 to L5. 7 cervical, 12 thoracic, 5 lumbar. You eat at 7 a.m., 12 noon, and 5 p.m. Here is the frontal lobe. Up here is the maxilla, the upper jaw. Down here is the mandible. Here is well, let's look at the choices. Can't be mandible, that's down here. Zygomatic bone, that's your cheekbone. Maxilla, upper jaw. Hyoid bone. Hyoid bone is actually the only bone in the body that doesn't articulate with any other bone. That's in the throat. Nasal bone. Yep, best answer, nasal bone. Well, if you haven't studied yet at this point, can you still figure it out? The hyoid was in the throat, and it's the only bone in the body that doesn't articulate with any other bone. When I think of palatine, I'm thinking hard and soft palate. When I think of zygomatic bone, I'm thinking about the zygomatic arch or the cheekbone. So now we have to choose between the lacrimal bone and the ethmoid bone. This happens to be the ethmoid bone. Okay, now we see something highlighted in here in the nose, and we see that there's a superior and inferior nasal concha. Typically when it comes to exams, when they put 2 things that are very close to one another, you'll probably have to choose between one or the other. But let's just look at the others. Vomer is this little extension here. This is the vomer. The perpendicular plate is the superior extension of that. So here to here is the perpendicular plate. Down here is the vomer. Together, we call that the nasal septum. So the nasal septum is made up of the vomer and the perpendicular plate. The lacrimal bones are here. So now it's superior nasal concha or inferior nasal concha. Well, I see one up here and I see one down here. Best answer, inferior nasal concha. The purpose of the nasal concha, also known as nasal turbinates, is that when you inhale and breathe air in, it spins it and centrifuges it. If you ever look at a shell or a concha, it looks like a spiral. Here's the vomer. That's the blue highlighted structure. Up here is the perpendicular plate. And if I were to cut this across and we were to look down and in to the skull, this structure would extend right up here through the ethmoid bone called a Crista Galli. We'll show you what that looks like. The blue bone here is the maxilla. The inferior bone would be the mandible, the lower jaw. So here's the lower jaw, here's the upper jaw, because that's the hard palate. These are the teeth. So would this be the mandibular teeth? No, mandible is down below. Would it be the incisive foramen? Well, incisive foramen is that little hole right there. Hard palate, that's the hard palate. Maxillary teeth, ding, 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 ding. It's the maxillary teeth for 1,000. Okay, down here, we're looking at the mandible, best answer. These holes that you can see here and here, those are called mental foramen. Mental foramen. Okay, what we're looking at here, this is the body of the mandible. That's the body of the mandible. Right here in the corner would be the angle of the mandible. This section here would be the ramus of the mandible. This right here is the coronoid process of the mandible. Sorry, let me go back here. I think I said this right here. Let me go back. This right here I said is the coronoid process. This, my bad, this is the coronoid process. This is the condyle or condylar process. Okay, because this condyle fits in this condylar fossa or depression right here. So coronoid process, condylar process. There in the throat, that is the hyoid bone. It's the only bone in the body that does not articulate with any other bone, but there are lots of muscles that attach to it. When we cover muscles next week, you'll hear of muscles called the stylohyoid muscle, the thyrohyoid muscle, the geniohyoid muscle. A lot of muscles attached there. Okay, so now we're looking at the mandible again. I said this here was called the coronoid process. This that makes up the TMJ, which is the temporal mandibular joint. This is the condylar process, also known as the mandibular condyle. That's what this is. Right here, this is the external auditory meatus, which is the hole in your ear where sound waves have to go through. This is the zygomatic bone. This is your frontal bone, parietal bone, temporal bone, occiput or occipital bone in the back. This is the squamous suture. Remember the word squamous? This is the squamous suture. This is the coronal suture. This is the lambdoidal suture. You can see it better from the back. The blue lines at the bottom pointing to these holes, that's the mental foramen. That's the mental foramen. Here we're looking at the eye, the orbit. There's lots of structures here to become familiar with. All of these openings or holes or foramen or canals or fissures are where cranial nerves are going to come through. Cranial nerves that control the eye. There are 6 eye muscles. We'll cover them when we cover muscles next week. But those 6 eye muscles are controlled by 3 cranial nerves. Cranial nerve 3, 4, and 6. Cranial nerve 3 is called the oculomotor nerve. Cranial nerve 4 is called the trochlear nerve. And cranial nerve 6 is the abducens nerve. And in that word, abducens, we hear the word abduct, which takes the eye and moves it away from midline, which is abduction. So that's what, every time you see a hole, nerves are going to be passing through there. So this optic canal right here is for your optic nerve, which doesn't move the eye, but it controls vision. That's cranial nerve number 2. So in terms of the eye, there's cranial nerve 2, 3, 4, and 6 that go to it. But 3, 4, and 6 move the eye. Cranial nerve 2 and cranial nerve 3 deal with vision to a degree. Okay? All right, so the optic canal is where the optic nerve or cranial nerve 2 travels through. There are 2 fissures. There's a superior orbital fissure, which is this slit, and then there's an inferior orbital fissure down here. Here's your ethmoid foramen, right here. Here's your infraorbital canal. Here's your zygomatic facial foramen. Remember, every time you hear the word foramen, that's a hole. So here's the infraorbital foramen, zygomatic facial foramen, the anterior ethmoid foramen. So there's going to be arteries and nerves and veins that travel through here. Let's look at this one here. Again, we're still looking at the eye and the orbit of the eye. Here is the orbital surface of the frontal bone, because this is frontal bone up here. So this is the orbital surface of the frontal bone. Here's the orbital surface of the maxilla, which is the upper jaw. Here's the orbital process of the palatine bone. Here's the orbital surface of the zygomatic bone, right? They're just extensions of other bones. And then here's the orbital surface of the greater wing. You're going to see the greater wing when you look at a bone called the sphenoid bone. The sphenoid has a greater wing and a lesser wing, but this is part of the sphenoid bone known as the bat bone or the butterfly bone, but it looks like 2 wings of a bat. Here is the squamous part of the temporal bone. So this is the temporal bone. This is the squamous suture. Sometimes they refer to this small little blue section as the squamous part of the temporal bone. Let's look at some of the sutures. So we're taking this part of the skull. This is the frontal bone. All the way in the back is the occipital bone. Going across this way is the coronal suture, sagittal suture. The sagittal suture is what separates the paired parietal bones, left and right parietal bone. Here's the lambdoidal suture back here. Lambdoidal suture, sagittal suture, coronal suture. Again, frontal bone, 2 parietal bones, and the occipital bone back here. Now, when you're looking in the skull, this is taking the crown portion off, looking in. So if you remember earlier when we looked at the nose, let me find my skull here. So when we look at the skull and we look right in the center of it, we have the bottom part, which is the vomer. Then you have the perpendicular plate. And then when we look at it from the inside, when we follow this septum right up to the top, it takes you right there, called the Crista Galli. That's where you feel the frozen brain syndrome. If you have ices or ice cream and you drink it way too fast, you get that frozen brain and you feel it right there, because what you're feeling is actually the olfactory nerve, which is cranial nerve 1 being stimulated, and the olfactory nerve permeates and perforates right through all of these holes. These holes are called the cribriform plate. in the center part, it's called a Crista Galli, and that's the extension of the perpendicular plate. Again, you have the olfactory nerve that comes right through here. What else do we have? This is your anterior cranial fossa, the middle cranial fossa, right? A fossa is just a smooth depression, and then a posterior cranial fossa. The large hole, remember, foramen just means hole, magnum means large, magnum foramen or foramen magnum. Here is the foramen lacerum. It means laceration. It looks like a knife went through here and perforated or lacerated this. Then you have three other holes, 1, 2, and 3. These are 3 foramen. I call it ROS, ROS. Foramen rotundum, foramen ovale, foramen spinosum. Foramen rotundum, foramen ovale, foramen spinosum, and this is the foramen lacerum. Again, everywhere you see a hole, there's going to be cranial nerves that travel through there. Cranial nerves are just nerves that come off of the brain. Right here, this is a really neat structure called the sella turcica, aka hypophyseal fossa. This is the infamous pituitary gland sits right here. And that's why when the pituitary gland enlarges or there's a pituitary tumor, here and here is the beginnings of the optic canal. So your optic nerves crisscross right here at this level. So clinically, when someone has a pituitary gland tumor and it enlarges, it can interfere with the transmission of nerve impulses through the optic nerve. Okay. Here is the clinoid process, this and this. This is just called a clinoid process. Anterior clinoid, and then on the back side are the posterior clinoid processes. Okay, what's the blue section right here? That's the cribriform plate of the ethmoid. That's where the olfactory nerve permeates through. Here's the incisive foramen. Here's the magnum foramen. Occipital condyles are here and here because this back of the skull is called the occiput, right? So now what are we looking at? This is the inferior surface of the entire skull. So that's the maxilla, the upper jaw, that's the hard palate. Those are the maxillary teeth. Here and here are the pterygoid processes, the medial and lateral pterygoid process. This is where 2 of your muscles of mastication begin. Muscles of mastication refer to chewing muscles. We'll talk about them next week when we cover muscles. Here and here are 2 holes on the inside of the magnum foramen called the hypoglossal canal. That's where your 12th cranial nerve travels through. Here's the opening of the carotid canal. So when you have arteries like the internal carotid artery or external carotid artery, that's where the carotid canal comes into play. Here's the mandibular fossa. Fossa, again, is a smooth depression. What is the purpose of that? Well, the purpose of that is for this, right? When we look at the TMJ, here is the mandibular condyle. It sits in the mandibular fossa to allow the jaw to open and close, okay? Here's the mastoid process and the styloid process. The mastoid process, you can really feel right behind your ear. So right here is the mastoid process. And then further in is the styloid process. Right there, styloid, mastoid. There's the external auditory meatus or the hole for hearing. And then there has to be an internal auditory meatus, which we can see near the petrous portion of the temporal bone. So that petrous portion, let me show you here. Here's the ear, right? So here's the external auditory meatus, right? Sound waves are going to come in through here, and it's going to hit the tympanic membrane, and it's going to shake the tympanic membrane right there, like a drum. It's going to vibrate that. It's going to vibrate the three smallest bones in the body, the malleus, incus, and the stapes. But right here is the petrous portion of the temporal bone. And when it comes off, we can see that there is a very important structure that lies in there. It looks like this. Looks like a snail. This is for hearing. And the upper part right here, these canals are for balance and equilibrium. It's called the vestibular canals. That's what hides deep inside this petrous portion of the temporal bone. The part that deals with hearing, the cochlea, and the parts that deal with balance, the vestibular canals. This is involved with vertigo, by the way. So when you have a patient that says when they turn their head to the right, it feels like they're spinning, or when they rotate in bed only in one direction, everything spins and they get what's called benign paroxysmal positional vertigo, that's because they have a problem in here. It is fixable. I get at least a dozen of these a year that I fix. It takes me about 5 minutes to fix it. And it really is a mechanical maneuver that's required. It doesn't necessarily require medications when it is a mechanical problem here. Okay. Also, many scoliosis that takes place in young children come from the output from the vestibular canals. Many times when babies are born and they're born with a forceps delivery, right, you can understand when tongues come around and clasp around the temporal bone and they squeeze in, it can distort what's happening in here. And when you get these aberrant messages, these vestibular canals have motor neurons that go to the muscles along the spine. So when you get more input to muscles on one side of the spine pulls in that one direction. It's pretty wild how that happens, isn't it? So many of these scoliosis that happen in younger children, I'll often do a case history and I'll ask, tell me about the birth process. Was it vaginal delivery? Was it C-section? Was it vacuum extraction or forceps? We see a lot of issues with vacuum extractions and forceps deliveries. Okay, back here in the back of the occiput is the EOP. EOP, the external occipital protuberance. That's this bump that we see right back here. The external occipital protuberance, right there. Okay, but then you also have to be familiar with the bones when you look at it from the inside, right? So we're taking the skull, we're slicing it this way, sagittally, and looking in. So again, there's the frontal bone, there's the nasal bone, the parietal bone, and the occipital bone, and the temporal bone. Here is the sphenoid bone, and closer to where that cribiform plate was is the ethmoid bone. And again, you have the mandible, lower jaw, upper jaw is the maxilla, and then the hard palate for the palatine bone. In the same area, we have some sinuses there, which are these chambers that help us produce sound, right? We have our, right, when your sinuses are clogged, you sound all nasal. So we have our frontal sinus here, and then you have a sphenoidal sinus here. Here is the groove for the sigmoid sinus. And here is the mylohyoid line. There's that word hyoid again. And then where's our pterygoid plate? Here is the medial pterygoid plate. When I treat patients that have TMJ, I have to go intraorally. I have to go to the back where that last tooth is and push upward right here to hit the muscles, to release the muscles inside the mouth to help with that temporal mandibular joint dysfunction. Very uncomfortable, very painful, but very effective treatment. So right up here, that is your frontal sinus, and then sphenoid sinus would be here. Here is the Crista Galli. of the ethmoid bone, just from a different perspective. Now we're looking at the 7 cervical vertebrae, the top one being the Atlas. C1 is Atlas, like the Greek god Atlas holds up the world. Just below the Atlas is the axis. C2 is known as the axis. Axis is for rotation of Atlas on top of that axis. So C1 rotates on C2. Let's look at the upper extremity. Here is the scapula. The scapula has some important landmarks. This is the spine of the scapula. That's how you know you're looking at it from the posteriors when you see this horizontal line. That's called the spine of the scapula. And the highest part of it is called the acromion process. The acromion process is part of the attachment site for the clavicle, which is on the anterior side. Here is the humerus. This is the head of the humerus. And on the outside is the greater tubercle. There's also a lesser tubercle, but we can only see it from the front. This is the glenoid cavity, also known as the glenoid fossa. It is the depression of which the glenoid cavity is the cavity for which the head of the humerus articulates with. Here is the ulna. This is the humerus, scapula, spine of the scapula. This is the medial border, or the vertebral border. This is the lateral border, or the axillary border. This is the superior border. Superior angle, inferior angle. Here's the distal end of the humerus. Then on the thumb side is the radius. Just remember, the thumb radiates out. The thumb radiates out, so the radius and the thumb are on the same side, whereas the pinky and the ulna are on the same side. So the radius and the ulnar are your forearm bones. The humerus is your arm bone. Distal to the radius and the humerus are the 8 carpal bones. Distal to the carpals are the metacarpals. Meta means after. So after the carpals are the metacarpals. And then distal to the carpals are the phalanges. When we look at the scapula from the posterior side, again, here's the spine of the scapula. Above it is the supraspinous fossa, and below it is the infraspinous fossa. On the anterior side, this is the subscapular fossa. Subscapular fossa. This is the coracoid process, which we can see here as well. And then above it is the acromion process, which we can see here. And again, the acromion process is just an extension of the spine of the scapula, which is this. Here's the spine of the scapula. We follow it up, and right there is the acromion process. Medial border, lateral border, superior border. The medial border, since it's closer to the spine, is also called the vertebral border. The lateral border, since it's closer to the armpit, is called the axillary border. And then here's where the head of the humerus articulates with, and that's the glenoid fossa or glenoid cavity. Close-up view. Now we're looking at it from the anterior, so we don't see the spine of the scapula. But here's your medial border, lateral border, superior border. Here's your inferior angle. There's your superior angle. Superior angle, inferior angle, superior border, lateral border, medial border. The other name for lateral border, since it's closer to the armpit, axillary border. The other name for medial border is the vertebral border. Up here, coracoid process. Here, acromion process. That's your glenoid cavity or glenoid fossa. The depression on the anterior scapula is the subscapular fossa. Here's the glenoid cavity that has a tubercle right here called the below, right? Infraglenoid tubercle. There's also a supraglenoid tubercle. You just can't see it because the coracoid process blocks it. Here's the acromion process, coracoid process, glenoid cavity. When you look at the clavicle from the superior view or inferior view, this is the lateral end. So the lateral end is going to articulate with the acromion process, so it's the acromial end. The other end articulates with the manubrium of the sternum, and that would be the sternal end. So this is the sternal end here and here, and this is the acromion end. It's a little bit flatter. What bone is this? So here's the clavicle. You can see that right there, this is the sternal end, because that's the manubrium. This is the body of the sternum. That would be the xiphoid process right at the tip here at the bottom. Here's the clavicle that articulates with the acromion process. That's the coracoid process of the scapula. Here's the humerus. The humerus is going to articulate with the head of the radius and the proximal ulna. Here is the head of the humerus. Now on this side here, we could see two different tubercles. This happens to be the lesser tubercle. This happens to be the greater tubercle. Between the greater tubercle and the lesser tubercle is the inter-tubercular groove or inter-tubercular sulcus. What travels through the inter-tubercular groove or inter-tubercular sulcus happens to be the bicipital tendon, specifically the long head of the biceps tendon. This is the humerus. Here's the medial epicondyle and the lateral epicondyle. Medial and lateral epicondyle. Here is the head of the radius. At the other end of the radius is the radial styloid or styloid process of the radius. Remember, the radius and the thumb are on the same side. Up here is the head of the radius. Here is the radial styloid. The head of the ulna is at the distal end. So that's what's interesting, right? The head of the radius is proximal, but the head of the ulna is distal. Here on the proximal ulna is the coronoid process here on the front. Coronoid process. Then you have your carpals, metacarpals, phalanges. So here are the 8 carpal bones, and they're specifically asking you for one of them. So you have to be able to name the 8 carpal bones. So there are 4 in the proximal row, and there are 4 in the distal row. And there's a little silly mnemonic. The silly mnemonic is some lovers try positions that they can't handle. So in the proximal row, some lovers try positions. Some, and when we talk about positions, I'm sure we're talking about Tai Chi or yoga or something like that, right? So some lovers, the S is for scaphoid, lovers is for lunate, tri for triquetrum, positions, P for pisiform. So some lovers try positions that they can't handle. That would be trapezium, they trapezoid, can't, capitate, handle, hamate. So again, that's proximal row first, then distal row, and we're going lateral to medial, right? Thumb side to pinky side. That's how you remember the names. So here, let's see. Some lovers trying positions that they can't. Capitate. It's the largest one, capital. It's the largest one. It's also in alignment with the third finger. When you fall with an outstretched hand, the one that fractures most commonly happens to be this one right here called a scaphoid. The scaphoid fractures most commonly. This one here subluxates most commonly. It's called a lunate. When the lunate subluxates or misaligns, it puts pressure on the median nerve, causing carpal tunnel syndrome, CTS. Okay, so we have carpals. Here are metacarpals, right? Those are carpals. Here are metacarpals, metacarpal 1, metacarpal 2, metacarpal 3, 4, 5. And then these are phalanges. And the phalanges also come in 3 flavors for digits 2, 3, 4, and 5. There's a proximal phalange, a middle phalange, and then a distal phalange for digits 2, 3, 4, and 5. The first digit only has a proximal and a distal phalange. There is no middle phalange of the first digit. Here's the spine. When we look at the spine, we have a lot of different landmarks of the spine. When we look at it from the lateral view, we can see there's a cervical curve, a cervical lordosis, a thoracic kyphosis, and a lumbar lordosis. On the outsides, what's blue here, those are the transverse processes. So let's take a look at some of the bony landmarks. When we look at a vertebra, this is the vertebral body. Off the body, we have 2 pedicles. Then after the pedicle, we come around, we have articular facets. When it's on the top, we call it a superior articulating facet. When it's on the bottom, an inferior articulating facet. We have a lamina here, and the 2 lamina fuse to form a spinous process. That's a spinous process. Then we have a transverse process along the sides. In the middle, that's where your spinal cord travels. That's called the vertebral foramen. On the vertebral body, that's where your disc is. So when a disc herniates and it pushes back, it can put pressure on the spinal cord. And then your spinal nerves come out here. One comes out this way, one comes out this way. So when a disc pushes back and hits a nerve, you can have radiating pain down your right arm, down your left arm, or right leg or left leg. Sometimes it goes down both when it pushes back against the spinal cord. So now we're looking at what's the highlighted structure. Here's the spinous process. These are the lamina. Laminas fuse to form the spinous process. When laminas do not fuse, we call it a spina bifida. When a spinous process doesn't form, spina bifida. This highlighted structure is the spinous process. Here's the vertebral body. Off the body are the 2 pedicles. This is the vertebral body. This happens to be the body of the axis, which is C2. C2 axis says right here, this is the only vertebra that has this structure called the odontoid process, also known as the dens. And when your atlas sits on top of it, it rotates around this structure. That's what allows you to shake your head no, or shake it from left to right. It rotates on its axis. So this would be the body of axis. When we look at a vertebra from the side view, we can still see the vertebral body. We could see the spinous process. We could see the transverse process. That's what's coming out towards you. And now I want you to see this is a thoracic vertebra. And remember what attaches to the 12 thoracic vertebrae are the ribs. So you'll see the word costal, 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 and costal. Costal means rib. So there is a superior costal facet. A facet is just a smooth surface, like the smooth surface of a diamond are called the facets. So here is the superior costal facet. Here's the inferior costal facet, and a transverse costal facet. So this tells you the path of which a rib articulates with the thoracic vertebrae. And that's why when the thoracic vertebrae rotate or move as they do with a scoliosis, the ribs move with it. Okay, this is a lumbar vertebra. The lumbar vertebra have pretty large, heavy vertebral bodies. Here is your transverse process. So that would be the TPs, transverse process. Spinous process is here. These are your pedicles. These are your lamina. Okay, we're looking at from the superior view. It says right here, superior. It's a cervical vertebrae. Most cervical vertebrae have these bifid, right, spinous processes like a fork. This is the superior articulating facet, and that's going to articulate with the vertebra above it to its inferior articulating facet. So you have an inferior articulating facet articulating with, you'll have a superior articulating facet on the one below, articulating with an inferior articulating facet from the vertebra above, and then they attach to one another. Okay, this is a thoracic vertebrae. This is the transverse process. So right there, the blue structure is the transverse costal facet. Now we're moving down to extremity. So here's your pelvic girdle. Here's your pelvic girdle here and here. Here's your sacrum, coccyx.
We lost you, Doc.
Okay. Let's try it again. Got me back?
Yes.
Perfect. Whoop. Let's go back here. Okay.
I only can hear you. I can't see your screen anymore.
Can everyone see my screen? Can everyone else see my screen right now?
No, it's
Yes, I see it.
blank.
I
We have
see it.
some yes. Okay. If you can see it, I'm going to attach the recorded video anyway at the end. We'll probably only have another 10 or 15 minutes. We'll be finishing up. So I will make sure that you guys get the recorded session of this. Because if I see it, then you can see it. If I see it on my screen, you should be able to. At least it's going to record it. You can still see it? Can you see the pelvis here? Some of you?
Yes.
Okay, great. So here's the pelvic girdle. Here's the pelvic girdle. Here's the sacrum. Here's the coccyx. This portion up here is called the ilium. You can see here the ilium, the pubic, and the ischium. Those three bones make up one of these sides, right? Called the ox coxa or the innominate bone, or the pelvic girdle is made up of the ilium, ischium, and pubic bone. Here's the pubic symphysis. This is the pelvic inlet. This is where, if this is a female pelvis, right here, this is where the baby has to descend through. Here's your fifth lumbar vertebra. Here's the last disc between L5 and sacrum. Here's the anterior sacrum. Here's your coccyx. So here's your pelvic inlet, that blue highlighted structure right there. This highlighted structure would be I would say it's the ilium, but since ilium is not a choice, this is a fossa called the iliac fossa. A major muscle is going to originate here called the iliacus. It's a major hip flexor. The pubis, that would be here. This is the pubic symphysis. This is the iliac crest, which is where your belt line would be. And this little bump right here is the this bump here is the anterior inferior iliac spine. That's this bump here. This bump up here would be the anterior superior iliac spine. So you have an anterior superior iliac spine and an anterior inferior iliac spine. And you have an iliac crest. Here's your SI joint. SI means sacroiliac joint. SI joint, sacroiliac joint. Again, that's your pubic symphysis. Remember, that's fibrocartilage. The largest foramen in the body is this one right here and this one right here. It's called the obturator foramen. Again, here's your anterior superior iliac spine. Here's the iliac fossa. Here's the anterior inferior iliac spine. The base of the sacrum is called the sacral ala. And the big dish right here where the head of the femur articulates is the acetabulum. Here is the sacral crest. Since it's midline, it's called a median sacral crest. This is only seen on the posterior view. Otherwise, on the anterior view, it's nice and smooth. The median crest would be analogous to the spinous processes of the vertebrae, but since the sacrum doesn't have spinous processes, it's just the median sacral crest. The anterior sacral foramina, these are the holes. Sacral foramina are here. The sacral hiatus, that's this opening or this gap right here. And then the ala of the sacrum are on the top or the sacral base here and here. On another view, this is looking at the pelvis from the side. Again, here's your iliac crest. Here's your acetabulum or acetabular fossa, pubic bone, obturator foramen, and the ischium. Again, same structures. Here's your iliac crest. This would be your anterior superior iliac spine, anterior inferior iliac spine, and you have the same thing on the back side. Posterior superior iliac spine, posterior inferior iliac spine. This is the ischium. This is the ischial spine. Difference between ischium, ischial tuberosity, and ischial spine. Above the ischial spine is the greater sciatic notch. Below it, lesser sciatic notch. So you have a greater sciatic notch, lesser sciatic notch, and guess what travels through there? Sciatic nerve. Looking at the lower end of the femur, that takes us to the lower leg, the tibia and the fibula. The tibia is the larger bone, fibula is the smaller, so just remember, you tell a small fib. Tibia is the larger bone, fibula is the smaller bone. At the distal ends of the tibia and the fibula, we have a medial malleolus, lateral malleolus. Medial malleolus, lateral malleolus. That's what people refer to as their ankle. Remember, in the hand you had carpal bones. In the foot we have tarsal bones, and there happen to be 7 tarsals. The ones that we can see here, the talus, and then the heel bone called the calcaneus. Here's the femur. Here's the kneecap called the patella. Just below the patella is the tibia, and this little highlighted portion here is a tubercle or tuberosity called the tibial tuberosity. It's at the same horizontal level as the head of the fibula. Happens to make a straight line if we went across. So tibial tuberosity, head of the fibula. Here's the sesamoid bone called the kneecap or patella. The top of it is called the base, the bottom of it is called the apex. When we take a close-up view of the knee, here is the patella surface. Why is that the patella surface? Because if I take this right here and I remove this down, right there's the patella, this is the patella surface right here. Here is the lateral condyle of the femur, and then there's a medial condyle of the femur. Inside or in between is soft tissue ligaments called the anterior cruciate ligament and a posterior cruciate ligament. Cruciate, like to crucify, it makes a cross. They crisscross in the center. That's why they're called cruciate. Anterior cruciate, posterior cruciate. This is the front of the tibia. So on the anterior part of the tibia is where the anterior cruciate ligament attaches, and on the posterior side is where the posterior cruciate ligament attaches. These can tear if the tibia is forced forward or forced backwards. I'll give you a classical example of this. You're sitting in the front seat of a car and someone's knees are on the dashboard. Sometimes people sit with their knees or their feet up when they're driving, or a passenger. If the knees are on the dashboard and then someone gets into a car accident and then the dashboard pushes the tibia posteriorly, you tear the posterior cruciate ligament. If you're running and you're playing football or soccer or something, and then someone tackles you from back to front and they drive your tibia anteriorly, you tear your anterior cruciate ligament. Okay? Here's the tibia. Here's the fibula. This happens to be the head of the fibula, and that right there is the tibial tuberosity. What's the function of the tibial tuberosity? Here's the function of it. Your quadriceps tendon attaches right to it. So when your quads contract, it allows you to kick or extend your leg. Between the knee, right, this is your meniscus, that fibrocartilage, and there's a medial and lateral meniscus. So which one are we looking at here? Well, here's the head of the fibula, and the fibula is the lateral bone. That would be analogous to like the radius, I guess, right? So that would be the lateral meniscus. Right here. This is your lateral collateral ligament, also known as the fibular collateral ligament. And this on this side is the medial collateral ligament, also known as the tibial collateral ligament. This is the lateral meniscus. Right here is the medial meniscus. So this one here, this is your tibial collateral ligament. This one here, fibular collateral ligament. Here is the femur. That's the head of the femur. Greater trochanter, lesser trochanter. Now we have these condyles here. This is the lateral condyle and medial condyle. So this is the lateral condyle of the femur. This is the shaft of the femur. This is anterior. And on the posterior side, we have this line called the linea aspera. Linea aspera. Here's the patellar surface that's highlighted. This is the articular surface. Well, what is this the articular surface of? This is the articular surface of the femur. This is the tibia. This is the fibula. Here's the lower leg. This is the tibial tuberosity. This is why it hurts so much when you get kicked in the shin. This anterior border, this crest, it's very sharp. Here's your medial malleolus and your lateral malleolus. That's the head of the fibula up here. There's your intercondylar eminence. Both lateral and medial malleolus clasp your ankle, or it clasps the talus bone. Tibia, fibula. So this blue highlighted one would be the fibula. Here's the head of the fibula. What's below anyone's head? The neck. That's the neck of the fibula. So head, neck, lateral malleolus down here, medial malleolus is just the distal extension of the tibia. Okay, what is the highlighted structure here? Remember the hand, you had carpals, metacarpals, and phalanges. In the foot, we call them tarsals, metatarsals, and phalanges. So these are the metatarsals. These are the phalanges, but which one? The great toe is 1, 2, 3. So this is your fourth metatarsal, which would be Roman numeral 4 right here. That's 1, 2, 3, 4, and 5. And then what do we have here? These are the phalanges. Proximal, middle, distal. Proximal, middle, distal. Proximal, middle, distal. But the great toe only has a proximal and distal phalange. The heel bone is called the calcaneus. This one right here is called the cuboid, and the cuboid articulates with the fourth and fifth metatarsal. This is the talus. This is the calcaneus. This is the cuboid. And then this one right here is called the navicular. And there's only three more, and they are the three cuneiform. They're called cuneiform 1, 2, and 3, from medial to lateral. Okay, I've seen this question pop up on some old exams where they give you all of the little bony landmarks, and then they give you a picture, and you just drag the different landmarks to the bone, right? So this is the femur, this is the tibia and the fibula, and then this bone is the pelvis, and they simply have you dragging the key structures to the bones that they are associated with. So just make sure that you review the main parts of the bone so you can do that yourself. I've often seen these type of questions pop up as well, where it's an x-ray. We do have students getting into radiology. So this is the lower leg. So you need to familiarize yourself a little bit with what structures we have. That's the femur, that's the patella, that's the tibial tuberosity, this is the tibia, that's the fibula, this is the articular surface of the medial condyle, this is the articular surface of the lateral, and then there's a little tubercle here called the adductor tubercle, which is where the adductor magnus attaches. And that's your kneecap called the patella. What are we looking at here? This is the cervical spine. This is C1. This is C1. So that's the anterior arch, and this is the posterior arch of the atlas. This is the axis, or C2. That's the dens, or the odontoid process. This is the spinous of C2, C3, C4, C5, C6, C7, also known as the most prominent vertebral segment, or vertebral prominence, which means that that's T1, which is your thoracic vertebrae. Okay, these are cervical vertebrae, and then that's your first thoracic. This is the base of the occiput. Okay, I think I am going to end it here. There's a few more things that are coming up, but I just want you on your time to just review the layers of the skin in terms of the epidermis. Make sure that you review the 7 layers of the epidermis so that you can identify them under a microscope as if you had to do it here, so that the top layer, you know, is the stratum corneum. The bottom layer would be the stratum basal. Make sure you feel comfortable with knowing the layers. My little silly mnemonic is Cher loves getting skin Botox. That's from superficial to deep. Stratum just means layer. So it's Cher loves getting skin Botox. Those are the layers from superficial to deep, so that you can then identify what some of the layers are of the epidermis, dermis, hypodermis. Again, so this would be the epidermis on top. Below the epidermis is the dermis, and then you have the hypodermis down below. Then just review some of the hair follicle stuff and review a little bit of the nails. Sometimes you'll see a little bit of the nails. What are some of the structures of the nails that pop up, like the nail body, which is here. This is the nail body. This is the free edge of the nail. Here's the lanula. Here is the nail root. And then here's the nail matrix, right? This is the first, this is like the distal phalange, okay? So that's the nail body. Right here is the nail root. And I was just wanting to go over some information with you in terms of how important the nails are to pick up some pathologies. So whenever I meet a patient and I shake their hand, I always look at the nails, because when I see clubbing, I know that there's some cardiovascular issue or some lung pathology that's going on. Sometimes I see it with irritable bowel syndrome. This is what clubbing looks like. This is normal. It gets very thick up here. Sometimes you see spooning of the nails, which is seen with fungal infections or diabetes. Sometimes you'll see anemia, lack of oxygen, or hypoxia, and the nails will look white. So I think B12 or iron deficiency. Here, this is typically seen with skin cancer. It's called a subungual melanoma when you see these black lines like that. Sometimes we'll see these ridges, which are seen with thyroid issues or endocrine issues, even B vitamin issues or diabetes. The nails are an extremely important part that you can pick up a lot of metabolic issues and a